Imagine this scene. You are 74. You feel fantastic. Your sleep is restful. Your vitality is solid. You are busy with hobbies you love. You head in for your standard yearly checkup, just routine. Your physician looks over your charts and remarks, "Hey, let's perform some screens just to be certain." A month and a half later, you are sitting inside a surgeon's clinic, not because you felt ill, but because those just to be certain screens discovered an issue. And that discovery triggered a sequence of medical actions that your 74-year-old frame was not prepared to endure. Now, the quiet life you were savoring looks entirely different. That specific narrative occurs far more frequently than the healthcare industry cares to acknowledge. The statistics regarding this deserve a very candid talk. My name is Dr. LANA, and this platform is focused on one goal: helping seniors over 60 comprehend what medical data actually indicates about their wellness in simple terms. What I am sharing today does not originate from a basic manual. It comes from decades of analyzing clinical reports and observing exactly what the data reveals when the healthcare system operates on autopilot. Here is the reality that most practitioners will not disclose during a brief 15-minute visit. Once you pass 70, several of the most routine clinical screens can actually inflict more injury than benefit. Not because healthcare is failing, but because the cost-to-benefit ratio shifts significantly as we age, and often nobody is evaluating that ratio in the room with you. Today, I am guiding you through 5 particular medical evaluations I would personally rethink after age 70. I will explain why the statistics shift. I will discuss what I have witnessed happen to actual patients, and by the end, I will provide a list of queries that will totally transform the rapport during your next clinical visit. Stay tuned for all 5 items because point 3 has stunned many individuals when they initially discover it. Additionally, point 5 is the one that most people never realize exists until the damage is done. Before we dive in, I would love your input. From where are you tuning in today? Share your town or nation in the comments. I read every post, and it truly assists me in identifying who is joining this group. Okay, let's begin. Before we analyze the 5 screens, I must explain one idea because without it, nothing I say will make complete sense. I term it the longevity lens. When you are 50, preventative screening functions perfectly. You detect a complication early, you address it, and you likely gain 30 additional years of vibrant life. The trade-off is logical. The statistics are clear. However, here is what shifts after 70. 3 factors specifically. First, many issues found by standard screening in seniors will never truly injure you. They develop slowly. They produce no symptoms. You will probably outlive them. Yet once they appear on a report, medicine lacks a leave it alone toggle. It only has a treat it toggle. Second, your body's capacity for surgical intervention decreases with age. The operation that a 55-year-old recovers from in a fortnight, that identical surgery in a 78-year-old can result in months of rehabilitation, setbacks, loss of autonomy, or worse. Third, there exists the cascade effect. One screen finds a minor quirk that sparks a secondary scan. The scan suggests a biopsy. The biopsy necessitates a procedure. The procedure results in a setback. Suddenly, an individual who entered feeling completely healthy is managing a clinical disaster, all initiated by a screen they never required. That is the longevity lens. Keep that concept ready as we evaluate each point. Before starting, take a moment and share your name and your location. I review the feedback and I sincerely want to know who I am guiding and helping here. Evaluation number 1. Standard colonoscopy after reaching age 75. Consider the story of Dorothy. Dorothy was 77, a former librarian from small-town Tennessee. She had undergone 2 colonoscopies in her 50s and 60s, both totally clear. No growths, no family history of colon malignancy, no issues at all. Yet her new family doctor reviewed her file and noted she was scheduled for another. Dorothy checked the facts. She had doubts, but she avoided being difficult, so she attended. The preparation, the fluid you drink the prior night to empty your gut, strained her kidneys severely. By the following dawn, she was confused, unsteady, and struggling to walk. Her child took her to the clinic before she ever reached the exam. She was intensely dehydrated, and her minerals were so dangerously depleted, her heart was failing. Dorothy spent 4 days in intensive care. She never received the colonoscopy. The irony, she never needed it. The United States Preventive Services Task Force, the premier organization that establishes screening protocols in this nation, formally advises against standard colonoscopy screening for average risk seniors past age 75. The data is definitive. After 75, if you lack symptoms, lack family history, and had clean past exams, the hazards start to exceed the gains. Those hazards are significant. Intestinal perforation, a physical rip in your gut, happens in roughly 1 out of every 500 exams. In a younger person, that is a solvable surgical setback. In a 77-year-old, it can require crisis surgery, a waste bag, long-term nursing, and a recovery that permanently alters your lifestyle. Furthermore, the colon malignancies most frequently found in symptom-free seniors tend to develop gradually, slowly enough that in many instances, they would never cause trouble in a person's remaining years. What should you do? Ask your physician about a non-invasive stool-derived test, like Cologuard or a yearly FIT kit. These can signal legitimate red flags without the procedural hazards. If you do show symptoms, blood in your stool, unexplained shifts in bathroom habits, that alters the situation completely, consult your doctor. Evaluation number 2, aggressive PSA testing and yearly mammography for low-risk seniors. I want to be very specific here because this subject requires balance. I am not suggesting you never screen for cancer. Oncology screening has preserved millions of lives, and it could certainly preserve yours. What I am declaring is this. After 75, intense cancer screening in average risk, asymptomatic people faces a massive overdiagnosis hurdle. Overdiagnosis leads straight to overtreatment. Here is what overdiagnosis signifies in simple terms. Imaging tools today are so precise they can find cancers that are, biologically, barely active. Small, slow-growing clusters that, if ignored, would never migrate, never cause pain, and never truncate your life. You would die with them, not because of them. However, the second a specialist types malignancy on a file, the medical engine engages. Biopsies, specialist visits, treatment plans, all of it proceeds regardless of whether the cancer actually threatens you. Reflect on a situation like Richard's, a 79-year-old former mechanic from Georgia, sharp, autonomous, still out fishing on Saturdays. A standard PSA test returned slightly high. A biopsy verified a low-level, slow-moving prostate cancer. His specialist suggested radiation. Richard believed the advice. He underwent the therapy. Within 12 months, he was battling constant exhaustion, bladder issues, and a lifestyle that had collapsed significantly. Accounts like his are recorded throughout clinical papers. Men who, in hindsight, wish they had grasped that their cancer was the sort of man his age would almost certainly have lived with, not died from. That insight, if provided sooner, could have altered everything. Research in the New England Journal of Medicine observed that a huge percentage of cancers found via mammography in women past 70 were clinically trivial, meaning therapy provided no survival gain, only side effects. What should you do? Have a candid talk with your practitioner about your unique risk profile. If you have family history, genetic markers, or symptoms, do the screen. If you are average risk without symptoms, ask your doctor plainly, if we detect something, what are the practical treatment paths for my age and what would we likely decide? That single query often shifts the perspective. If you are still watching and find this useful, please type 2 in the comments. It signals to me that you are engaged and benefiting from this. Evaluation number 3, standard heart stress testing without symptoms. This one shocks people because it appears so prudent. Your doctor says, "You're 72. Let's just ensure your heart is functioning well." You climb on a machine or they inject a drug that briefly taxes your heart and track the results. Seems harmless, seems diligent. Here is the issue. Cardiac stress tests in individuals without symptoms have false positive frequencies that can hit 40% or more in certain groups. That means nearly half the time, the test signals a flaw when your heart is actually healthy. But medicine cannot simply ignore a flagged result. That false alarm pushes you into the subsequent step, a cardiac catheterization. Catheterization involves sliding a narrow tube through your veins, usually through your arm or leg, straight into your heart. It is a major intervention. Hazards include bleeding, artery trauma, heart rhythm issues, and in rare cases, it can spark the exact cardiac event or stroke you were aiming to avoid. Here is where it becomes even more illogical. If the catheterization detects a partial clog, which is incredibly common in seniors over 70, many of whom feel fine, you might receive a heart stent. Several major clinical studies, including the famous ischemia trial, observed that stenting in patients with stable heart disease did not decrease heart attacks or prolong life compared to pills and habit changes alone. Let me repeat that. The stent was not more helpful than the pills, but it carried genuine surgical risks. Then comes a lifetime of blood thinners with their own internal bleeding hazards. So you transitioned from feeling great to a standard test, to a false alarm, to a catheterization, to a stent, to blood thinners, to constant monitoring, and you are no better off statistically than someone who simply used medication and a 30-minute daily walk. What should you do? If you have no chest pressure, no weird breathlessness, no fainting during movement, standard stress testing is hunting for issues in a group where issues are normal and surgery doesn't always help. Talk to your practitioner about improving your risk variables instead: blood pressure, cholesterol, glucose, activity, sleep. That is where real progress happens. Evaluation number 4. Standard bone density DEXA screening with immediate pills. Here is one that makes folks uneasy when I mention it because bone loss is serious and falling is catastrophic for seniors. So let me be precise. I am not doubting the reality of bone thinning with age. I am doubting the immediate pipeline that frequently follows a DEXA result in patients over 75. A scan finds low density. Your doctor orders a bisphosphonate, drugs like Fosamax or Actinol. You take them for years, believing you are safe. But here is what often goes unsaid. Extended use of these drugs has been linked to a rare but major issue called atypical femoral fractures. Sudden stress breaks in the leg bone, the very bone you were attempting to save. These breaks can be catastrophic and require hardware. Furthermore, these drugs are connected to jawbone death, bone rot in the mouth that is agonizing and very tough to fix. Meanwhile, the most powerful tool for stopping breaks in seniors, without exception, isn't a pill. It is fall prevention, balance drills. Research indicates Tai Chi specifically lowers fall hazards by almost 50%. Clearing rug hazards from the house, adding handrails, checking for drug reactions that cause vertigo, getting eyes tested, and ensuring enough protein and vitamin D. These actions lower fracture risk more effectively than any tablet with zero complications. I am not saying never take drugs for bones. There are certainly patients who require it, those who have broken bones, those with extremely low T-scores, those with specific risks. But a standard DEXA leading to automatic long-term drugs for an active 74-year-old who has never fractured anything and is otherwise fit, that is a talk worth having, not a certainty. What to ask your doctor before starting drugs? Can we check my fall risk factors? And what is the real-world fracture reduction from this drug compared to a formal fall prevention plan? If you have gotten this far and find this helpful, type 4 in the comments. It's a quick way to show you are here and listening. Evaluation number 5. Symptom-free carotid artery ultrasound screening. This is the one almost nobody mentions, and based on the data, it is one of the most quietly dangerous. A carotid ultrasound inspects the big pipes in your neck that deliver blood to your brain. The concept is easy. If we find a big clog, we can surgically scrape it and lower your stroke risk. Logical, right? The truth is far more messy and for symptom-free patients far more risky than it sounds. Here is the vital statistic. The surgery used to clear a carotid clog, called an endarterectomy, carries a 2% to 3% risk of triggering a stroke during or right after the procedure. In seniors, particularly those with other conditions, that risk rises. The United States Preventive Services Task Force specifically advises against standard carotid screening in people who have no symptoms, no mini strokes, no sight loss, no brain-related symptoms. Their study found that in healthy people, the hazard of surgical injury exceeds the gain. Here is why. Many folks over 70 have some level of tightening in their carotid pipes. That tightening has often existed for decades, stable, quiet, not causing any trouble. When you screen for it regularly, you find it, and then a well-meaning surgeon suggests fixing it. But the surgery to repair a clog that was never causing trouble can, and sometimes does, bump a tiny speck of debris that goes straight to the brain. I won't share a single story for this one because the recorded data is too heavy to simplify into one person. The clinical papers show individuals entering a standard screening visit and exiting on a totally different life path than they ever envisioned, not because of the clog found, but because of the surgery that followed. What should you do? If you lack stroke symptoms or TIA signs, no sudden vision shifts, no face drooping, no arm limpness, no sudden crushing headache, then standard carotid ultrasound is generally not advised. The far wiser effort is in managing the actual changeable risk factors: hypertension, the primary stroke cause, blood sugar, quitting smoking, heart rhythm control, and moving more. If you do show any neurological signs, even short ones that vanished, get checked fast. That changes the plan. Practical system, the 5-query protocol. I promised you a tool you can use, so here it is. Every time your physician suggests a screen, especially if you are over 70 and feeling fine, I want you to have these 5 queries ready. Note them down, save them in your phone, take them to every visit. Query 1. What is the false positive frequency of this screen for my age? This reveals how likely the screen is to spark useless secondary tests, even if you are fine. Query 2. If this screen detects something, what are the practical treatment paths for someone my age and health? This pushes the talk toward results, not just sightings. Query 3. What is the surgical risk of any therapy we would likely follow? This is the query most people never think to raise. Every intervention has a cost. You deserve to know it early. Query 4. What occurs if we track this instead of operating? For many issues found in seniors, watchful monitoring is a valid and often better choice. Query 5. What is the most powerful, non-surgical path for this issue? Because very often, as with bones, heart, and stroke safety, lifestyle and drugs beat surgery with much less danger. Any decent doctor will appreciate these queries. They will value you more for raising them. If your doctor ignores these queries or makes you feel annoying for asking, that is vital data about whether that physician is the right match for you. I want to end with this. There is a gap between medicine that finds stuff and medicine that helps you live well. After 70, the aim of your care shouldn't be to produce data. It should be to guard and prolong your lifestyle, your freedom, your drive, and your ability to do what counts. The best doctors I have ever met realize that doing less sometimes requires more skill than doing more. Recommending monitoring takes more guts than ordering another test. You have the right to know what a screen is seeking. You have the right to know what happens if something is found. You have the right to ask if a finding would actually be operated on and if that operation would truly improve your days. Medicine has provided us amazing gear, but gear is only useful when used in the right setting at the right moment for the right person. You are that person, and you deserve a medical journey that is centered on your aims, your principles, and your body, not on a form. If this clip provided a new way to view your health after 70, please join us. I produce clips like this weekly, useful, data-backed, and direct to help you govern your wellness in the years that count most. Leave a note below. Have you ever had a standard screen that led somewhere you didn't plan? Your story might be exactly what someone else requires to read before their next visit. Stay healthy. See you in the next.